preparing. אוקיי, היי, ערב טוב לכולם. אני מקווה שכולם רואים ושומעים כמו שצריך. אז היי, מרגש מאוד. אני הילה וייס מעמותת הגם, וכאן איתי דנה סטיינברג, חברת הקהילה שלנו, ואנחנו כאן בוובינר על בעיות אי יציבות צווארית ובעיות נוירולוגיות באהלרס-דנלוס, והוא מועבר לנו על ידי דוקטור פאולו בולונז. אוקיי, היי, ערב טוב לכולם. כאן איתי דוקטור איילין רוהוי. רגע, אני רק אסדר פה את הסאונד. אוקיי. אז אנחנו כאן עם דוקטור פאולו בולונז ודוקטור איילין רוהוי, שניהם מניו יורק, מארצות הברית, והם מנהלי המרכז של EDS וכיארי בבית חולים דרום נאסאו בניו יורק. דוקטור בולונז הוא נוירוכירורג ומומחה בעל שם עולמי ביישומי לייזר דופלר בנוירוכירורגיה, ודוקטור רוהוי היא נוירולוגית מוסמכת מטעם ארגון הבורד האמריקאי, ומתמחה בנוירולוגיית מבוגרים וילדים, והיא גם כן חברה בצוות המחקר והטיפול בבעיות נוירולוגיות בעמותת EDS הבינלאומית. אנחנו נעשה חלק של הרצאה, ובסופו בערך רבע שעה של שאלות ותשובות. מי שצופה בנו עכשיו דרך הממשק של הלייב, אתם תוכלו לשאול שאלות, וחלק מהן יענו בסוף הוובינר, וכמובן מזכירה שלא יהיה אפשר לענות על שאלות שמצריכות היכרות עם הרקע הרפואי שלכם. אז אני אעבור לאנגלית. Good evening everybody, I'm Hila Weiss, I'm CEO and co-founder of AGAM, which is the Israeli EDS Society. We're here with Dana Steinberg, our community member, and Dr. Paaulо Bolognese and Dr. Eileen Rouhoi in a webinar on neck instability and neurological aspects in Ehlers-Danlos syndrome. Dr. Bolognese is the surgical director and Dr. Rouhoi is the medical director of the EDS and Kיארי Center at Mount Sinai South Nassau Hospital, New York City. Dr. Bolognese is a neurosurgeon and a leading worldwide expert in the field of laser Doppler flowmetry applied to neurosurgery. And Dr. Rouhoi is a board-certified neurologist trained in both pediatric and adult neurology, and she is also a member of the Neurology Working Group of the International Consortium in the Ehlers-Danlos Society. So Dr. Bolognese and Dr. Rouhoi, thank you so much for being here tonight with us and giving us these talks. Everyone is quite expecting to hear you, and I'm going to, the floor is yours, Dr. Bolognese. Give the mic to you.
Thank you very much. It's nice to be here. It's actually quite exciting. And I'm going to go straight to my slides. I'm going to keep the speech restricted to craniocervical instability and ME/CFS because this is kind of the new and sexy subtopic of all the things we do. First of all, a little bit of terminology. The craniocervical junction is the bone and ligament box around the things we deal with. The cervicomedullary junction is the content of this box, and it reflects the passage between the spinal cord and the brainstem. The craniocervical instability is the problem related to the box with consequence on its content. And the cervicomedullary syndrome is the voice of the problem, which is the sum of all the signs and symptoms that come from this problem. I have to premise that I added much more information that I'm going to talk about in these slides, and I'm going to share it with the moderator, who's going to share it with you, all you guys, as a sort of an opportunity for you to have, to dig deeper. The preface. The fatigue by itself is something that we have seen as a symptom in many of the neurosurgical pathology we have dealt with. And we have noticed that the fatigue, as all the other symptoms involved in these diseases, tend to improve after surgery. And this is an observation which is old, more than 20 years. About ME/CFS, flipping the things on the other side, we know already for more than 20 years. The beginning was called in a different way, but now it's been rebranded. We know that there is a big overlap between the symptoms of ME/CFS and the symptoms of the disorders affecting the craniocervical junction, which is the limit between the skull and the neck. Some of our patients have a formal diagnosis of ME/CFS, and we know that they have improved in all the ME/CFS or in part of the ME/CFS ankles after the neurosurgical procedure we're doing. Does that mean that all the people with the ME/CFS have a neurosurgical problem? Absolutely not. The people with ME/CFS with a neurosurgical problem at its base or is a comorbidity, which means that there's a partner in crime, they're less than 10% as far as we can assess now. First of all, everybody is aware about what the brain is, what their brain is located. The lowest part is called the brainstem, and it looks like this, is a front and is in its back. And it's a very complicated piece of what are called electrical cable assembly. There are some cables which pass by, which are all the cables bringing the sensation, the sensory information to the brain and conveying the motor information from the brain to the periphery. But there are also some circuits which are not passing by, but they belong to the brainstem alone. And there are a bunch of them. I'm just going to go through the major one. One is the reticular formation, which is what keeps us awake and keeps us asleep at night. Another one is a bunch of cables that regulate our breathing, regulate our heart rate, regulate the correct movement of our eyes in reference to the moving world around us, regulate our ability to focus on the acoustic information coming from the outside, and regulate the pain. So under stressful circumstances, we can, when we're running away from a tiger, we can ignore that we have a twisted ankle. And other times when we have more time to focus on our pain, we feel it stronger, even if it's the same twisted ankle. So all the regulation comes from the brainstem. And in the brainstem, there are also some special nerves that originate from there. And the most important nerves for our part is going to be the nerves of the neurovegetative system. This is just a schematic of all the nerves starting from the brainstem, but one of the most important is the parasympathetic. And you can understand that a lot of these, if that nerve does not work right, all this list of systems can be negatively affected. And you understand why the ME/CFS has all these problems listed, amongst its own problems. The most vulnerable spot for the brainstem, which is a sturdy part, is the lowest part. It's a funny word, it's called the medulla oblongata. It's the lowest part, and it's a transition point between the brainstem itself and the spinal cord. And it is located next to a choke point, which is called the Foramen Magnum, which in Latin means the big hole. So opening the skull from above, you can easily see which one is the big hole. And out of the words I said before, which is the cervicomedullary syndrome, which is the voice of our problem. What's a syndrome? A syndrome is a complex of symptoms which belong to a specific area of the nervous system or of any part of the body. And the cervicomedullary junction, as I said before, is the transition zone between the brainstem, the medulla, and the spinal cord. Once we have just done that, once we identify what's a cervicomedullary syndrome, which is something which happens whenever there is a pathology here, there is a constellation of signs and symptoms which take place. What's a sign? Sign is something everybody can see from the outside, like a paralysis. A symptom is something that only the patient feels and has to describe on the outside. So as you see here, there is a long list, and the fatigue is the very, in the bottom of the second column, and there are many, many others. Why? Because as you've seen, that part of the brainstem has a very complex system of cables passing, in and out and throughout. And therefore, whenever any one of these cables or all these cables are affected, you can have a big amount of trouble. The pathologies hitting that area are many, and trauma, tumors, infections, etc. Does not matter what the pathology is. You're always going to have the same signs and symptoms. What makes a difference is the speed. So if you crash in a car at high speed and 80 or 150 kilometers per hour, and your head does like this, that area gets affected. But you're having a trauma which hits that area harsh and fast. Tumors, they're not growing in a matter of a few seconds. Tumors can grow over a matter of months or years. So it's a pathology which is a class of pathology which is lower and progressive. But there is a number of pathologies, which is what of interest here in reference to ME/CFS, which keep going, affecting that area, but they're very slow acting. So they like we say in, I'm not a cook, but like we say in the kitchen, it keeps going on simmer. And that's the key for the fatigue or the anything like ME/CFS to be either aggravated or to be caused in the first place by these pathologies. So what can go on in this specific area, the junction between the skull and the neck? You can have problems which are static or dynamic. Now, the static anomalies, they're so self-evident, even a medical student can pick it on. So this is normal anatomy, and this is the abnormal anatomy. So big difference between normal and abnormal. And you are born with that. Just growing up makes some little differences, but you are born that way. The dynamic problems, they are linked to instability, and sometimes they're evident, sometimes they're less evident. In this case, it's something dynamic. Dynamic can be a tumor growing here, like the picture on the left, or a major problem like that one on the right. Now, in this case, whenever there is Ehlers-Danlos syndrome involved, the Ehlers-Danlos syndrome affects the ligaments. The ligaments are the rubber bands keeping the bones together, keeping the joint together. And here you see just the schematic of the craniocervical junction seen sideways, and all the the things in blue on the left side, those are the ligaments. And then here seen from the back to the front. As you see, there's quite a complex layering of these cables. Now, what was important for us for the understanding of EDS and craniocervical instability was a case that we had more than 20 years ago. So you understand when you have a tumor or a trauma, the things are self-evident. Here in this case, we had the patient who came to us with an extremely debilitated on a wheelchair. She was 16, and she had also, on top of many other things, an extreme fatigue. So in retrospect was what we define now as a ME/CFS patient. The MRI was far away from the positivity or those things self-evident we saw before. Was something which was practically normal. But we figured out early in the game that pulling up the head made her feel better. So not knowing what was going on, or at least having a vague idea that the ligaments could have been compromised, we fixed the head in an extractive position. So we pulled up the head, which is the position that she experienced, during which she experienced feeling better. And we just fixed it that way with screws and bars. She had a recovery which was much more than we expected, and this 16-year-old became actually a supermodel for the following 4 or 5 years with one of the most prestigious, firms in the world. And then she abandoned the career when she became older. And now I'm the proud uncle of 2 little children. So this led 7 years after that first case to a first article, which was followed by another article describing that people with EDS can have pathologies affecting the junction between the skull and the neck that are not easy to see radiologically, but if you bear that in mind, can be fixed with a big clinical improvement. So we have something that is not really visible. So how do we get there? How do we screen the people who have this from the people who do not have this? So the first thing, the screening, there are three things which have nothing to do with the radiological studies. The first to do is tell me your story and I manipulate your head. So if you have the list of the symptoms, even total or partial, of the symptoms which would occur here, if you had any pathology here, at that point you had my attention. The second one, if you have a history which smells like EDS, compounded by some aggravating factors like trauma or infections, etc., at that point you have my attention the second time. But the third thing is provocative test. If I have a broken arm and somebody manipulates my arm, I'm going to complain. I'm going to tell the guy, don't do it anymore because it hurts me. So if I have a problem here and I do manipulations for the neck, making it worse or making it better, at that point you have my attention the third time, and we go to the next level, which is we screened you in the system, and now we have to confirm our suspicion. To confirming our suspicion, we do it with neuroimaging, with measurements of the neuroimaging, and then we finalize it with the test called invasive cervical traction. So the morphometrics, you guys have already heard this term, again, is more than 20 years old. And they've been traditionally more than 20 measurements for the craniocervical junction. And some of these measurements are as old as I am. But the majority of these measurements were used for trauma or for recognized congenital deformities. So with the help of our good friend Misao Nishikawa, who spent 6 years from now, and now is chairman in Osaka, we restricted these 20 plus to 4. And this is the list of the 4, and I'm going to go through it. Now, this is what you need for the measurements to, the very minimum you need, the standard cervical MRI done in a closed machine in supine position, and the measurements have to be done on a T2 sequence, which means when the CSF is wide, on a mid-sagittal image, which means you cut your body from the nose to the, to the back of the neck. This is the single image on which we can do the measurements. Anything else, you cannot have accurate images. Now, this joint moves in different direction, moves rotationally, moves anterior, posterior, and also has a vertical dimension. And these 4 parameters are sensitive to instability in a certain direction. So CXA and PBC2, which is the grab, and in part the BAI are for the horizontal component, but the only one for the vertical is the BDI. This is an example of the grab and the CXA. And what's the grab? The grab is a measurement between 2 reference points, and it is sensitive to the mass, it's sensitive to the horizontal direction, and expresses the ability of a pathology to exert a mass effect on the brainstem. So if the brainstem is on the right side of those lines, you understand that anything which projects more and more towards the right is going to push the brainstem over. So mass effect is that, and we have discussed over the years what is the normal range, but right now anything above 8.5 millimeters is considered pathological, but not necessarily reflects in a problem, as we're going to see. So as you see here, there is a difference between here, where there is the brainstem, between the brainstem and that black complex of the ligament, there is a little bit of a white space, and here there is no space left. Now, the clavoaxial angle expresses the stress deformity. Stress deformity is an easy concept from your own experience. So if you want to break a stick and you use your knees, you understand you're going to see that the first thing to break is not the inside of the stick, but the outside of the stick, that one away from your knee. So that's stress, the concept of stress deformity. Long story short, anything more than 145 is normal, everything less than 135 is considered abnormal. And then we go to this, for example, is 123. But okay, so in the grounds of this, if somebody would have the the instinct of saying, okay, we put everybody in line, we do grab and CXA, and everybody who has normal, abnormal, okay, go back home or come on over. No, it doesn't work like that. So this is something which is called the lack of specificity of the test. Long story short, many people with abnormal grab and CXA don't have symptoms, and therefore they don't belong in an office of any center dealing with this. And many people with normal grab and CXA are unstable and they're very symptomatic. Example, you go to the Olympics and you go to the gymnastics events, all the people who are doing gymnastics at high level have EDS. And you're going to find monster values of grab and CXA. You cannot tell these guys you are sick and you need a surgery. These guys are going to laugh because not only they're human, they're superhuman for the things they do. All right. The other two parameters called the BDI and the BAI, which are the oblique line and the horizontal line. The vertical line is a reference line. These lines were introduced for trauma, for a pathological craniocervical dissociation, which has nothing to do with EDS. And they've been re-evaluated in a dynamic fashion for EDS and craniocervical instability. The dynamic way means we compare the value you have off traction with the value you have on traction. And obviously it has to be under certain control circumstances. And the thing which is the most important is that BDI is the only parameters out of all these four, which is affected by the vertical instability. All right, so you need to do it before traction and during traction under comparable circumstances.
Paolo, just to interrupt you for a moment, to say that we have 5 minutes, more or less.
I'm almost done, so I'm good.
Oh, great, thanks.
So the invasive cervical traction is a test that we use to confirm the instability to the highest possible degree. There are 5 parts attached to the traction. That, again, as promised, you can review on your own. But for us, the important thing is that we bring them in the operating room and we put them sitting and we put this device, which is attached to the skull. We do off traction, without weights, and on traction. So all these girls have one thing in common: they're smiling because they are during the traction and they're experiencing a big improvement of all their symptoms. So, and this is a classic example of a me-CFS, a person that is before the traction with the device on the head without the weights, and with the device with the weights on. What do we see different? We have the traction is divided in 2 pieces of information. One is the clinical improvement. You see at 30 pounds, all the symptoms are improved between 90 and 100% from the baseline. And the lower box is definitely the measurements. The biggest difference here is between the BDI off traction and the BDI on traction. And everything which changes more than 2 millimeters for the BDI is pathologic. So in this case, we have an improvement of all the symptoms, including the fatigue, because of that 4 millimeter change of the BDI. This is another example, same thing. Surgery. We have done this surgery, as I told you, the first time on EDS people, more than 20 years ago. And the first 10 years, we say, all right, we know how to do it because we do it in trauma all the time. And then we discovered that people with EDS they're different from others, and you cannot treat them the same way with the same instrumentation and under the same premises, because, as Dr. Rouhoi is going to say, there are a lot of other things connected to EDS which can affect the outcome. So the second 10 years, we changed radically our surgical and medical approach, and we had a massive improvement in significant improvement in our results. In common, we fixed the joint. We fixed the joint between the craniocervi, between the skull and the neck. But how we do it and all the things that are done to treat all the medical problems which surround the craniocervical instability are even more important. So at the beginning, this was the craniocervical fusion that we were doing, very good. Somebody who doesn't have EDS and you treat them for trauma of else, they kiss you on the way out, kiss your feet on the way out to the hospital. And then we discovered that these patients, this fusion geometry is not well tolerated by EDS patients for a number of different reasons. They have what is called the princess and the pea principle, the metal fatigue principle, blah, blah, blah. You know, they're better, but they're not super happy. So we change our approach. Instead of fusing in the back of the skull, we fuse underneath the skull. We fuse in a part of the skull called the condyle. And this is the, so you see that the hardware is much different compared to this. In this distribution, same principle, fusing the skull to the neck. So, and this is the joint we want to fuse, and this is the joint fused. But with that and all the knowledge of the pathologies Dr. Rouhoi is going to shortly talk about, that made the difference in terms of outcome. So then we started seeing new patterns that made us even more aware about things we did not know before. These are all lessons learned in the last 5 years, if you forget about the last 20. And this take-home message. There are a number of different pathologies at the craniocervical junction that can cause a clinical picture which overlaps with a ME/CFS. These pathologies hurt you by hurting the medulla oblongata, which is part of the brainstem. And in order to cause a ME/CFS symptoms, again, in less than 10% of the ME/CFS patients, these pathologies have to be hurting you by simmering. But so it cannot be something too strong, too fast. It is to be something kind of not super weak, but a little bit of mild to moderate, and has to be simmering there for years. And the principle is, if once we figure out how to screen, select in the patients that we can help, whatever is mechanical can be helped with the craniocervical fusion, but the concept is patient selection. So now I'm going to come out of here. And I'm going to pass back the baton.
Thank you so much, Dr. Bolognese. You already answered a ton of questions, and I'm sure people are bringing up some more. So thank you, and Dr. Rouhoi, we're with you now.
Okay, so I'm going to share my screen. Can everyone see this screen? Does that work? Okay.
Yeah.
So,
yeah.
Right. So I think that, so Dr. Bolognese sort of mentioned all the different other pathologies that go along with CCI and EDS patients, and I'm certainly not going to touch on all of them. We sort of talk about the septat patient, and now we're even, then the number just keeps increasing of the different comorbidities that we see. So I'm just going to briefly touch on largely about POTS, but also there's a little bit of a mention of small fiber neuropathy and MCAS. And so I'll just get started since we don't have a lot of time, so I have no relevant disclosures. So just a quick overview about the autonomic nervous system, which sustains the biological homeostasis. So it keeps us working at rest. It keeps us working in response. It keeps everything copacetic. It is part of the peripheral nervous system, which is also the peripheral nervous system is broken down into the somatic, the autonomic, and the enteric nervous system. Somatic is voluntary movement, and autonomic and enteric are involuntary. And then the autonomic nervous system is divided into two parts: the sympathetic system, which sort of controls lots of different things that we don't really think about: our blood pressure, our thermoregulation, response to stress. Its major neurotransmitter is norepinephrine, except for the sweat glands, which use acetylcholine, and the adrenal medulla, which uses epinephrine. And then the parasympathetic system, which controls how our saliva, our tears, our pupillary responses to light, our heart rate, the motility of our gastrointestinal tract, how we urinate, erectile function, and its major neurotransmitter is acetylcholine. And so it's important to know that while we often talk about the peripheral nervous system and the central nervous system, which is the brain and the spinal cord, there's a lot of integration that goes on with the autonomic nervous system. And we think that that's part of the reason why we see so much comorbidities in EDS patients when it comes to dysautonomia. So for example, the insular cortex, the anterior and mid-cingulate cortex, and the amygdala generate autonomic responses for any kind of behavioral response from an exogenous or even endogenous stressor. There are hypothalamic nuclei that generate coordinated patterns of autonomic responses to stressors. And then there are several brainstem nuclei, specifically in the medulla, that participate in integrated control of any autonomic function that relates to respiration or the circadian rhythm. And there's also connections between the brainstem nuclei and the hypothalamus. So there's a lot of integration that goes on in general with our autonomic nervous system in the way it interacts and behaves with not only our internal environment, but our external environment as well. And so these are just sort of diagrams of, this is the sympathetic nervous system, and you can see that the neurons stem from the thoracocolumbar area, and then they synapse on paravertebral and prevertebral ganglia. And then this is the parasympathetic system, which is largely in the cranial sacral areas. And again, they control different aspects of our autonomic nervous system. And so when our autonomic nervous system is impaired or deficient in any way or becomes dysfunctional, you can imagine how these opposing forces can create a lot of different symptoms, and that's exactly what happens. There are a lot of symptoms that patients will report and present with that are related to some level of dysfunction of the autonomic nervous system, usually of either the parasympathetic or sympathetic, or sometimes the response of one to the other. And it can control how labile our blood pressure is, whether it goes up, whether it goes down appropriately, our heart rate, how our bowel functions, how our bladder functions, how we sweat or don't sweat sometimes, how our sexual function is, and our pupils. And so the normal response to when we stand is from the baroreflex, which is located in the carotid sinus, is that there's a small fall in systolic blood pressure and a rise in diastolic blood pressure, and that's to the order of 5 to 10 millimeters of mercury, and then a rise in our heart rate to about 10 to 20 beats per minute. And so the sensitivity of our baroreflex can sometimes be measured as sort of how well it controls our heart rate. And it has been shown to be more sensitive in hypermobile patients. And we don't understand the exact reason behind that, but we do think that's related to the higher incidence of orthostatic intolerance or dysautonomia that we see in hypermobility EDS. And so orthostatic intolerance is sort of an umbrella which encompasses both neurogenic orthostatic hypotension and postural orthostatic tachycardia syndrome, otherwise known as POTS. And then there's also a third category of vasovagal syncope, but I regularly see that in the context of POTS. And POTS is thought to be that the blood pressure is maintained by a compensatory tachycardia because the baroreflex, which is meant to keep blood pressure at a very even level in response to certainly orthostatic stress. So when we stand in different positions, because it's so sensitive, it cannot keep the blood pressure maintained. So there's a compensatory tachycardia that results, hence the elevated heart rate in POTS syndromes. And what that does is preserves cardiac output. And so neurogenic orthostatic hypotension is a sustained reduction of blood pressure that is greater than or equal to 20 millimeters of mercury of systolic pressure and 10 millimeters of mercury of diastolic pressure that occurs within 3 minutes of standing or head-up tilt. With the head-up tilt tests, some in the tilt table testing, some clinics actually have more rigid criteria because it's considered passive standing. So you don't recruit what we refer to as the muscular pump of our lower limbs to sort of help maintain blood pressure. So because it's more passive standing, some clinics hold a higher criteria, more rigid criteria to diagnose neurogenic orthostatic hypotension based on tilt table. With postural orthostatic tachycardia syndrome, POTS, there is a sustained increase of heart rate of at least 30 beats per minute within 10 minutes of standing or head-up tilt, but it also has to be symptomatic. And that's something that a lot of patients don't understand, that it doesn't it's not only that it meets the criteria of increasing the heart rate of 30 beats per minute, but also it has to be symptomatic. And those symptoms are symptoms of cerebral hypoperfusion or sympathetic activation. And approximately a third of the patients, and as I said earlier, with POTS also have vasovagal syncope that's associated with position change. So it's not clear if this is just a spectrum or a separate entity. It does seem to be more of a spectrum. And a common comorbidity is joint hypermobility. So POTS symptoms, again, symptoms of both cerebral hypoperfusion and sympathetic activation is tachycardia, which again is a cardinal feature of POTS. And it's an appropriate cardinal feature because one, it's the most prominent. Two, it's easily accessible. So we can measure it very easily as opposed to some of the other symptoms, which do have some subjective components. But there's also palpitations, dyspnea, tremulousness, lightheadedness, diaphoresis, which is sweating, nausea, sometimes vomiting, headaches, blurred vision, pallor, coat hanger pain, which is sort of pain in the upper traps and the upper back and the neck and the shoulders, anxiety, fecal urgency, and brain fog. And many patients have non-orthostatic symptoms. So there's chronic fatigue, which is very commonly seen in patients with both hypermobility and POTS. Circadian rhythm disorders, there's often a sleep-wake cycle dysfunction and very, very often non-restorative sleep, despite the fact that some will report many hours of sleep. It is non-refreshed sleep and they still feel tired when they wake in the morning and very tired during the day. Gastrointestinal difficulties, often it goes from constipation to diarrhea to lots of dysmotility issues that have some combination of both constipation and diarrhea, often dyspepsia, where they feel bloated and have abdominal pain, interstitial cystitis, so lots of bladder kinds of concerns with whether it's hesitancy, urgency, retention, incontinence. A great percentage have an exercise intolerance, which is also thought to be about deconditioning, and then fatigability, where the slightest any movement or trying to do any task of daily living can create fatigue that is seemingly disproportionate to the movement that occurred. And these symptoms are often exacerbated by lots of different things, specifically medications like tricyclic antidepressants, SSRIs, stimulants, antihypertensives such as diuretics or sympathomimetics. Some vasodilators can exacerbate these symptoms. Anything that causes prolonged recumbency, such as viral illnesses or physical trauma like concussions or other kinds of physical trauma, heavy meals, heat exposure, intense physical activity, or any illness. And so when we stand, there is usually a redistribution of blood volume but if with appropriate normal venomotor and vasomotor tone, actually that the vessels of our lower limbs, of our lower extremities will help to counteract the pooling of blood because of gravity when we stand. But when we have any kind of level of dysfunction or adrenergic denervation, there is pooling of our blood to the splanchnic mesenteric bed, and it is unopposed. And so we have basically low volume, low plasma and total blood volume. And that is what creates reduction of blood flow back to the heart. So it's lower preload onto the heart, and therefore it decreases stroke volume. And this then unloads the baroreceptors, and then we have excessive sympathetic outflow. And we think that is the pathophysiology behind POTS. And in fact, when we have prolonged standing, the radial pulse can sometimes become difficult to palpate, again, because of the pooling of the blood, and the blood becomes very stagnant. And we also can have acral coldness, swelling, or blueness. In fact, many patients have often reported that their hands or their feet will swell, that they have cold feet, that seems abnormal to them, that they didn't have earlier, that they develop these symptoms that seem weird to them, and they happen to mention it. And it is very consistent with what we think about the pathophysiology behind POTS. So the mechanisms, there have been quite a few that have been studied and discussed, but there's a lot of different overlap. So there definitely is a level of volume dysregulation. And we talked a little bit about hypovolemia already, where there's reduced cardiac preload. and it unloads the baroreceptors, and it results in a sympathetic outflow, which results in the tachycardia. There's venous pooling, again, because there's unopposed adrenergic innervation of the blood flow because of gravity that sort of is, again, it's redistributed to the splanchnic mesenteric bed. Compression garments can sometimes reverse this when the pressure is such that it reduces venous capacitance. And then there's capillary leakage. If you think about the blood that becomes stagnant and sits in these vessels, ultimately there's capillary leakage where the vessels become porous, and that actually just compounds the venous pooling and the hypovolemia. There's also a level of impaired cerebral autoregulation, and we have found in certain small studies that there is a cerebral hypoperfusion from reduction of cerebral blood flow velocity during head up tilt. And that's an important, I think, physiologic parameter that I know that we plan on studying a little bit further with the use of transcranial Dopplers at Mount Sinai South Nassau. Other mechanisms that are very commonly discussed are hyperadrenergic versus neuropathic POTS. With hyperadrenergic, there is both primary and secondary, and primary hyperadrenergic POTS tends to have very excessive levels of standing norepinephrine in the order of 1,000 to 2,000 picograms per milliliter. And then secondary hyperadrenergic spots. So primary is about 5 to 10% of the hyperadrenergic POTS cases. And then the secondary hyperadrenergic POTS is thought to be related to mast cell activation. And that's not really a topic of this conversation, but with mast cell activation, we can see a lot of hyperadrenergic states. And so there's lots of flushing and diarrhea and nausea and vomiting, along with the POTS symptoms of tachycardia. And so we think that the secondary hyperadrenergic type of POTS is related to mast cell activation, which we very often see in hypermobility patients. And again, this can be triggered by standing, exercise, emotional stimuli, physical stress. And then the neuropathic POTS is just impaired sympathetically mediated vasoconstriction. So there's there is adrenergic and pseudomotor denervation. And as I said, that then it doesn't oppose the gravity result of the pooling of the blood from standing. And we also sometimes identify the alpha-3 subunit antibodies. So there are antibodies that are created against the ganglionic nicotinic acetylcholine receptor, specifically of this particular receptor, the alpha-3 subunit. Now, this same antibody can actually attack thyroid antigens as well, so it's very important to assess for thyroid function. But when this antibody attacks the ganglionic nicotinic acetylcholine receptor, it's something we call autoimmune autonomic ganglionopathy. And we have actually identified that in several cases of neuropathic POTS, and it's been reported in the literature as well. And then deconditioning is thought to contribute to POTS as well. And the great percentage of POTS patients have exercise intolerance. And in these patients, they definitely have greater and more persistent tachycardia. So even with provocation, so all POTS patients, obviously, in order to have the diagnosis to meet the criteria, you have to have the elevated heart rate greater than 30 beats per minute on provocation. So we can do orthostatics in the clinic. There's something called the NASA lean test that many physicians will have patients do at home. I do autonomic testing, which is a lot more specific and reliable. And so, but beyond the provocation, they will have even just resting heart rates that are much higher. So, and that is related to deconditioning. And in these patients, they almost always have exercise intolerance. And some actually have reduced stroke volume and left ventricular mass on studies. And so that's also considered to be an important POTS mechanism. And so, as I said, the sympathetic noradrenergic system is very much involved. But despite, we try very hard, our first primary mode of treatment is to try to control heart rate, but that doesn't seem to completely resolve most of the other symptoms that we see with POTS-like syndromes. And so we think that there's a contributory role of abnormal processing of our other organs, basically, they're involved, which is sort of the integration that I referred to earlier. It's not just simply about the baroreflex and the response of our heart to orthostatic stress. And then, as I said, symptoms often develop rapidly after a viral illness or for other reasons of prolonged bed rest. And then there's been some conversation that perhaps it's related to post-infectious autoimmune problems. I mean, again, the ganglionic nicotinic acetylcholine receptor antibody is one antibody that we've identified. There have been some other antibodies that have been discussed. So is this an autoimmune disorder that is a result of infectious processes? Those kinds of questions, the answers at least are still underway. So the management of POTS, again, compression is very useful. Compression garments such as abdominal binders and compression socks. The goal is to, again, reduce venous capacitance. So it helps to create more venomotor tone to sort of push that blood back up to the heart. So there's appropriate preload and appropriate stroke volume. Fluids, so replace fluids each day, trying to keep intravascular volume up, which is important. It helps to counteract the cerebral hypoperfusion. So we recommend about 2 liters each day. But importantly, you have to add salt to that or other electrolytes because healthy functioning kidneys will excrete free water. So just the hydration itself is not as helpful as when you add salt to it to sort of keep that volume within the intravascular space. And the recommended dose is 5 to 10 grams of table salt, which is equivalent to 2 to 4 grams of sodium daily. I always recommend these counter maneuvers for patients when they're actually having acute symptoms of POTS, such as crossing the legs and squatting, sitting up slowly when you go from a supine to a sitting position, to put your feet on the floor and allow the physiology to calibrate a little bit before you stand up very slowly, and then wait a few seconds before you take your first steps. I think exercise is a little bit controversial. I talk about just sort of at least keeping legs straight. You know, that's why I mentioned the passive standing. It's important that we recruit the muscular pumps of our lower limbs. And so it is important that we try to maintain strength in our legs for sure to allow for that kind of muscular pump activity for when we stand. That pump activity does help somewhat to improve the blood flow so that it doesn't pool down in our lower bodies. And so gradually reconditioning is important. And then there are certain medications, of course, that will help to decrease heart rate, increase blood pressure, such as beta blockers, midodrine, fludrocortisone, and then IV fluids. You know, we try, if patients can't maintain oral hydration enough, many patients benefit greatly from IV access fluids. In fact, many of them will get them weekly, if not more often. The problem with EDS patients, of course, is that sometimes the veins, because there is vascular connective tissue that we think is also contributing to the problem in POTS with regards to the lower limb muscular pump, is that the vascular connective tissue is impaired, the structural integrity is not as sound. So oftentimes the veins won't allow access for regular periods of time. So we try to do other forms of access, such as midlines, PICC lines, and ports. And so pharmacologic management of POTS, you know, beta blockers is recommended for hyperadrenergic, at least first line. Pyridostigmine is really helpful to counteract some of the symptoms of POTS. Fludrocortisone will help expand the plasma volume via sodium retention. Midodrine is an alpha-1 agonist. It's actually very helpful. It helps to elicit peripheral vasoconstriction. I find it more helpful than fludrocortisone in most of my patients. And it's really helpful for neuropathic POTS, again, because of the adrenergic denervation that we see. And then droxidopa has been very helpful for neuropathic as well. And ivabradine is really great for inappropriate sinus tachycardia, which is sort of resting heart rate of greater than 100 beats per minute and palpitations. And it's related to some sympathetic dysfunction and not necessarily a dysfunctional pacemaker automaticity. So it's really helpful in POTS patients where there's persistent tachycardia. Comorbidities seen, again, chronic fatigue, chronic pain, insomnia, fibromyalgia, headache. Actually, greater than 50% of patients will have migraines, joint hypermobility, mast cell activation. Mitral valve prolapse is the most common cardiac abnormality that we see. Inappropriate sinus tachycardia, and then the median arcuate ligament syndrome, which is really interesting because there's compression of the celiac artery, and there's different techniques to correct it when it exists, but one of the techniques is to basically disconnect from the celiac ganglion, which is a a collection of basically autonomic nerves. And what's interesting is that vascular surgeons tell me that when they do that technique, a lot of the POTS symptoms are improved. So that's interesting because it does connect to the mesenteric splanchnic bed that I refer to, which is where the blood pools when we stand. And so I wonder what pathophysiology underlies there that might help us give other answers in the future. So there is an evaluation for POTS that we do. Obviously, a great history is really important of both orthostatic and non-orthostatic symptoms. What are the triggers? What's fluid status? How much are people drinking during the day? What's their electrolyte and caffeine intake like? Physical activity? How often do they sit? How often do they stand? What treatments have they tried in their response? And a good review of systems, because sometimes there are certain symptoms that people report based on organ system review that aren't necessarily thought by them to be orthostatic or non-orthostatic, and just things that they've been dealing with their lives, and they just thought, well, that's just what I have to deal with. We do cardiac evaluation to just make sure there isn't a cardiogenic etiology of their symptoms with EKG, Holter, and echo. Neurologic evaluation, of course, I do lots of autonomic nervous system testing as well as skin biopsies for small fiber neuropathy. A laboratory evaluation, which is fairly comprehensive. Actually, 24-hour urinary sodium excretion testing really helps to assess for hypovolemia. And then other causes for autoimmunity or for small fiber neuropathy. And then obviously testing catecholamines and norepinephrine can help for assessing for hyperadrenergic POTS. There's a lot of, I send them to gastroenterologists. We do a lot of motility studies, and as well as to urologists for urodynamics. And then, I always do my MRIs, obviously looking for CCI and AAI, as well as I regularly do myelograms, because sometimes some of the symptoms can be related to CSF leaks. And we know that hypermobility type EDS, there is a greater risk of CSF leaks. And so sometimes I want to make sure that some of the symptoms aren't because of that, because of low intracranial hypotension. And so this is a tilt table testing. You can see at the bottom screen, part of the screen is sort of where we tilt. And then you can see at the top level is the heart rate, and then in the middle is the blood pressure. There is irritability of the blood pressure just because of orthostatic stress, but there isn't actually a change of blood pressure measurements, if you can see. But with the heart rate, there's an increase of the heart rate. And full autonomic testing should actually also include not just tilt table, but the Valsalva, the heart rate, deep breathing, and the Q-SART. The Valsalva is important because when you watch the blood pressure control, sometimes with hyperadrenergic, you can see in certain phases of the Valsalva, you can see overshoots that are very consistent with hyperadrenergic POTS. So I think it's important to check. And then actually, even with heart rate, deep breathing, you can see certain patterns that are consistent with cerebral autoregulation. And Q-SART is the sweat test, and it correlates very easily with the thermoregulatory sweat test. And it's very much related to small fiber neuropathies. So at the bottom screen is the Valsalva test that I was referring to, and you could sort of see the blood pressure overshoot in phase 4, which at the bottom of the screen, you could see with the Roman numerals where it labels the different phases. So it's phase 1, early phase 2, late phase 2, and then phase 3 and phase 4. And this is where you can see the vasovagal syncope in a patient that had a diagnosis of POTS, and you can sort of see towards the end of the tilt where the heart rate and the blood pressure decreased, and that's where the patient has syncope or fainting. And then small fiber neuropathy. So there's a lot of symptoms, but very often, small fibers are often pain fibers, but they can have other sensory deficits as well. So there's pain and dysesthesia, there's numbness, paresthesias. There's a lot of autonomic symptoms because the small fibers do control much of our autonomic nervous system, specifically the gastrointestinal tract. Our motility is controlled by small fibers. So that's another reason behind dysmotility and dyspepsia. And a lot of patients are diagnosed with things like SIBO and leaky gut. And that makes sense because things just become stagnant. And when anything becomes stagnant, then things happen that shouldn't happen. Just like when blood becomes stagnant, you can form clots, you can form capillary leakage. And similar in the bowel, when the bowel becomes stagnant, obviously, then you can have overgrowth of certain bacteria. But it also controls our cardiovascular system, the cutaneous vasomotor system, the urogenital system, and temperature dysregulation. So many patients with small fiber neuropathy can't tolerate heat, or they can't tolerate cold, or they're cold when they should be hot, they're hot when they should be cold. a skin biopsy is the gold standard, and it measures the intraepidermal innervation. And so that is how we diagnose skin biopsy. Small fibers cannot be picked up on EMG, but I do EMGs regardless because you want to make sure there isn't a large fiber component. But by definition, a purely small fiber neuropathy should have normal EMG studies. And then labs, there's a neuropathy labs to be done because neuropathies can be caused by other things, and you just sort of want to rule out and make sure there isn't another contributing component. So diabetes and plasma cell dyscrasias and thyroid dysfunction, autoimmune disease like Sjogren's, for example, nutritional concerns like B12 deficiencies, folate deficiencies, and then autoimmune autonomic ganglionopathies. And then 50% of them are actually idiopathic. So despite our best attempts at trying to diagnose the reasons why, half the time we can't find out why. And then finally, a recent paper just came out. So there is a lab that also tests not only for small fiber neuropathy, but for synuclein deposits. Synucleinopathies in neurology are, the most common one, of course, is Parkinson's disease, but it's Parkinson's disease and Lewy body dementia and multiple system atrophy, and then even Parkinsonism, so secondary Parkinson's. These are all synucleinopathies that have a very important dysautonomic component to them. And so I've been testing for synucleinopathy, for synuclein deposits in the skin biopsies along with small fiber neuropathy for a while now. And my colleague, Dr. Todd Levine, recently came out with a paper that showed that there is a certain percentage of POTS patients that will have synuclein deposits on skin biopsy, and that these patients with POTS and with synuclein and small fiber neuropathy seem to have a more severe phenotype. They have more persistent or severe symptoms. And that's, this is sort of new research, so we're not really sure what to make of it just yet, but it is interesting that his paper is actually very similar to my experience in my clinic with patients. And so it's going to be interesting to sort of see over the next couple of months and years what information we find out that will better help patients to really sort of control their symptoms. Because as I said earlier, controlling their heart rate does not seem to completely resolve their symptoms, and certainly doesn't seem to cure what the ligamentous laxity had caused, which would include, of course, the CCI. So that is my talk, and I'll take any questions.
Thank you so much, Dr. Rouhoi. Super, super, super informative and helpful. We do have several questions. Dana, if you can come back to us, and Dr. Bolognese as well.
Yes. Can you hear me, Sini?
Hear you, yes. See you. Yeah, go.
Okay. So we have some questions for Dr. Bolognese. We're going to start with questions about craniocervical instability. Some of the questions were actually answered, which is great, during the lecture. I'll read the first question that we got here. So the first question for you, Dr. Bolognese, is if there are any treatments for craniocervical instability except surgery. Any kind of physiotherapy or using neck braces. This is the first question.
I'm going to jump on that. The surgery is just when everything else has failed, and when the severity of the disease has reached the point of no return. For now, the things which are recognized to work in people with instability is to reinforce the muscles of the neck and of the core, to use orthotics, which are, cervical collar, under specific circumstances in which we need extra protection, and then cervical traction used with moderation in order to, quote unquote, reset the joint in the same way you would reset a computer. This is what we use all the time. Now there is a number of things that we're considering now, and we have to refine. And some of them two of the most likely candidates are the prolotherapy and the stem cell therapy. Right now, we do not know. The evidence is that they do not help the people who already have fallen off the cliff. I have yet to see a patient who's so severe that he needs surgery or qualifies for surgery, need is a relative term, who were cured or brought back from the brink by stem cell therapy or prolong. But you know, these things need to be refined. We need, you know, the specialists who are involved need to be a little bit more consistent in the way that they apply the protocols. There is still something to do, but for sure they're promising.
Okay, I will thank you for the answer, but I have another question to add to this, if it's okay. How long, let's say a person is doing physiotherapy and is trying to get his muscles, strengthen his muscles, how long can a person do that until he can say, okay, this doesn't help?
Yeah, there is no, the concept of flipping the thing around. The main issue is when somebody needs to pull the trigger on the surgical decision. And the surgical decision, the vast majority of the times, is based on the fact that surgery is an option. Is an option which is given in addition to the conservative management when somebody qualifies certain qualification criteria. And the in vitro cervical traction is one of the examples. You know, once we are in that, with that kind of frame of mind, there is no specific end to which somebody will say, oh my God, you know, I'm running late for taking my surgical decision, or, you know, I'm nervous that if I wait too long, you know, the surgery is not going to be enough. The only things that we have to be worried are if the patient is starting taking heavy-duty narcotics, like things like OxyContin or whatever equivalent in terms of name you have in Israel. Once somebody takes the heavy-duty narcotics, the clock is ticking, and you should not take them for more than 2 years before taking the surgical decision, for reasons which are a little bit complex to just to tell in a short answer. The second thing is if there are deficits appearing, you know, if you start becoming starts becoming a chore, not only a chore, but starts becoming so problematic to swallow, for example, that you need a permanent feeding tube. You start becoming such a problem to breathe that you need oxygen, or you need a pacemaker to move your diaphragm. At that point, obviously, we're at the point in which surgical is no longer an option, but becomes like a forced decision. But everything else, you know, the patient should try everything before having the peace of mind of saying, all right, I've tried really everything and I go ahead with the surgery. Providing that somebody doesn't have a neurological deficit or is not, you know, the clock is not ticking on narcotics, the time, it's an open-ended proposition.
This is okay. I think this makes everything clearer about the surgery. There is another question here about what kind of movement disorders can craniocervical instability cause? What would a person feel in terms of mobility, I guess?
Okay, there are two issues here. Number one is the movement disorder per se. There are some problems which come from the brainstem, which are called pseudo seizures. Pseudo seizure is a kind of a generic term in which somebody has a movement which is uncontrollable, and the EEG is negative, therefore it gets called pseudo seizure. Unfortunately, pseudo seizure sometimes is an umbrella term, and it covers movement disorders which come from psychiatric problems, or sometimes come from just from the brainstem being irritated, and that's what it is. And it's very difficult for a neurologist who doesn't have a big experience in this field to make to distinguish one from the other. So very often, some patients with craniocervical instability, they get labeled as crazy, and because they have this pseudo seizure, and everything gets wrapped up in the same package. On the other end, there is the other nuance of the question was that one of what's happening to the motion of the craniocervical joint. The motion of the craniocervical joint can, before or after the surgery, before the surgery can have a big range. So some people can have an enormous mobility of the joint. Other people can have just a couple of millimeters, and they can have the same clinical compromise. So it is not that important just to focus on the motion, but everything has to be taken in the bigger picture, everything together. The third thing is if somebody has a surgery and has EDS, the restriction of the motion is only 25%, which is different from the more than 50% restriction after surgery. People who do not have EDS have experience after a craniocervical fusion surgery.
Wow. Okay. Do we have time for more questions?
That's fine. I'm here.
And if we have, there are more questions here. Okay, I think another question about the mobility after the surgery was answered right now, which is great. There's a question about herniated discs and bulging discs, if the connection to craniocervical instability, if craniocervical instability can cause herniated discs and vice versa.
All right. There are two aspects of the problem. First of all, people with EDS have a tendency to have disc herniations and subluxations very often. It's these like they sublux their joints, sublux their shoulders, sublux their ankles. The same can happen over here below in the lower part of the cervical spine. Generally, the herniated disc happen between C4 and C7. That's where they're packed. Now, after a craniocervical fusion, you can have also dislocation and disc herniations, but it's a matter of degree. The mistake we were doing during the first 10 years we were doing these fusions was that we did not understand that the EDS people are a totally different tribe altogether, and they have rules of their own. So in the past, we were saying, okay, this patient, the craniocervical instability up here, and they have a disc herniation down here, let's incorporate everything together. That would have worked for anybody else, but for somebody with EDS. So the concept for people with EDS is you fuse late and you fuse short, which is the exact opposite of what something that you would do for something who doesn't have EDS. So the concept is whenever somebody has instability and they go to a standard neurosurgeon, they're going to get distracted by the herniated discs, and they're not going to, quote unquote, see the craniocervical instability. For us, is the opposite. We do not particularly care about small disc herniations and small subluxations because they don't really matter. They're part of the panorama in people with EDS. And we just jump on top when they really become big and they really give unequivocal signs and symptoms. Now, what happens afterwards is that you can have something called the next level disease. If immediately below the fusion, because now instead of just the skull and two vertebrae, the skull and the two vertebrae, they're one piece. Immediately below the fusion, there is the tendency for that uneven teeter-totter to create a subluxation and eventually even a disc herniation. The chances for that to happen between the second and the third cervical vertebrae are the smallest chances out of the entire cervical spine. So it's for that reason that in people with EDS, we keep with the craniocervical fusion the shortest possible and not below C2. It's quite unusual for somebody to require a extension of the fusion on the large numbers of EDS. But if you start with a fusion which goes from the skull to C4, at that point is pretty much the chances for that domino effect to start is 10 times higher.
Wow.
But these are all things that we didn't find in any book. We just found them by getting the eggs on the face and by doing things that we would have done on anybody else, but we discovered the hard way they were not working on EDS people the same way.
Wow. Okay, this is great. There's one more question that you started speaking about, you started mentioning about breathing. And there is a question here about breathing problems. And someone was asking what type of breathing issues can cryocervical be?
People with mild to moderate effects on the breathing have, after instability, they feel that they are short in breath. They feel they cannot take a deep breath. They feel that they are kind of constantly trying to catch up. The most severe forms of breathing instability, which are extremely rare and only found in a handful of people, they are such that the brainstem is compromised so much that is not able to tell the lungs, breathe in, breathe out. And at that point, the patients need to be either on a ventilator or they need to be on a special machine. It is the pacemaker tells the heart when to beat. The phrenic pacemaker tells the phrenic nerve, which is the nerve commanding the diaphragm, when to move and when to suck the air in for the lungs. These things are extremely, extremely rare. And, so the vast majority of the people, we should not be worried about that.
It means that if a person would have it, you would know.
I only found 2 people with the pacemaker, with the diaphragmatic pacemaker in my entire career. And I've operated on more than 1,000 patients with CCI and EDS. So it's a very, very small number.
Wow. Okay.
Very reassuring.
Yeah.
Thank you, Dr. Bolognese. We have some questions for you, Dr. Rouhoi. So we'll go to that. First will be, is there such a thing as borderline POTS in terms of either symptom severity, as in less severe, or partiality? For example, only temperature dysregulation and sweating or sleep difficulties, but without obvious tachycardial symptoms. And you did mention that tachycardia is cardinal to the diagnosis, but more than one person asked this. And so could this be? And if so, then what are the possible treatments for the 2 possible expressions of either partiality or severity of the symptoms?
So I think, obviously in the name POTS, it says tachycardia. So that's why it's considered a cardinal symptom and a cardinal feature. I have a lot of patients who definitely have an elevated heart rate on tilt, but don't necessarily meet the criteria of 30 beats per minute. And so I call them borderline POTS. And I do believe that sometimes that's affected by medications that they've been on. And while we try to recommend, we give them a list of medications to stop at a certain period of time, not all of them do, not all of them can. Some actually become very sick if they try to stop their medication. So sometimes that criteria can be affected by that. It's also affected by hydration status, maybe meals that they've had, maybe stress in their lives. So I personally think that if they're symptomatic on any level, and not anyone needs to have all of those symptoms that I had listed, certainly, and they do demonstrate an elevated heart rate, albeit not at 30 beats per minute, then I would consider them they are on the POTS spectrum, and I would treat them accordingly. Actually, it's sort of what I do. But medicine likes to have defined criteria on how to get diagnoses, and I think we all know that not everyone fits in a nice neat box for various reasons. And so, like I said, usually there's some reason why they haven't met that very rigid criteria of 30 beats per minute. But I would consider borderline to be POTS and treat them as such. And if they respond, then I think that that's another diagnostic marker.
Yeah, they respond to the intervention. Makes sense. Okay, great. Another one is more about small fiber neuropathy. If you get a negative result for small fiber neuropathy via biopsy in one limb, does it completely rule out small fiber neuropathy in the whole body?
No, not at all. In fact, one of the features of small fiber neuropathy that's interesting as opposed to large fiber neuropathies, there could be length dependent, both small and large fiber for sure, but small fibers, their distribution in our body is very different than the long fibers. And so sometimes it can be patchy, actually. In fact, patients come and they say they have patchy, numbness along their bodies. Some have, things like a burning mouth syndrome, for example, is an often type of descriptive symptom that patients will report with small fiber neuropathy. So in the skin biopsy, the gold standard is really 3 separate biopsies. And I have found that not all physicians are doing 3 biopsies, and you really need to, because, doing one, and if it's normal, doesn't rule out small fiber neuropathy, because as I said, it can be elsewhere. And so I regularly do 3. And if all 3 come back negative, then chances are there is not a small fiber neuropathy. But if a small fiber neuropathy is present, then one of at least 3 will be positive. So, yes, so it does. So if one is negative, that does not rule out small fiber neuropathy, no. Especially if it's just in one area that's length. Most people will do the foot because of length dependency, but again, those rules don't necessarily apply to small fiber neuropathy. They often do, but not always.
Okay, great. In continuation, another question was, what is the most recommended treatment today for small fiber neuropathy?
Oh, that's a great question. It really does, it's symptomatic. So it really does depend upon what the most prominent symptoms are that are related to that neuropathy. The reason why I do such an extensive workup on small fiber neuropathy is because my neuropathy panel, for example, is a whole list of things that have treatable options. So, you don't want to miss an etiology that has a good treatment, right? So that is why I look for other causes of neuropathy. And occasionally I find other causes and we can treat them. But when everything on the labs come back normal, and then they are presenting with just clearly autonomic type symptoms, then it's more of a symptomatic approach, definitely. I will say that if I find evidence of autoimmunity, whether it's the acetylcholine receptor antibody that I had recommended, I will say there are a lot of other antibodies that we look for, then I will do an autoimmune approach, and many patients actually do very well with IVIG. But very difficult to get approved here in the States, at least. There are very few indications for insurance approval, and small fiber neuropathy is not one of them. So it's hard to get approved unless I can find, like I said, a more discrete autoantibody that might give me fodder for the insurance company to recognize how this patient will benefit from IVIG. But it has been very effective for patients who have received it, for sure.
Wow, really good to know. Okay, several, do we have time for like 2-3 more questions?
I have time for one.
I have time.
Okay, so there were some questions about like the interface between the different things. And for example, how do you tell if the symptoms are caused by CSF leak or by dysautonomia or by CCI when the exams don't show an obvious leak? But
that is easy. All 3 mechanisms, they are linked to position. So in all 3 mechanisms, somebody sits up, stands up, and they're worse. But in all 3 have a peculiar provocative test. In one, you pull up or you push down, and you're respectively better and worse. That is instability. The other one, which is the CSF leak, you do a blood patch and it is better and doesn't care at all about the manipulation of the neck. And then the third one, which was the dysautonomia, it's been already explained by Dr. Rouhoi. And the trick is that in some patients, you can have 2 or 3 coexisting. So at that point, you have to layer the workup. But the difference is about what's the mechanism and how you recognize is pretty, is pretty linear. The point is, don't panic, just work them up one at a time and you're gonna get there.
Okay, great. Thank you so much, both of you. People have tons of more questions, but we don't have time, unfortunately, for that. But we want to thank you so much for being with us here tonight and giving us tons of information. And thank you, everyone here, for watching us. Thank you, Dana. Super grateful for this opportunity.
Thank you for having us.
Okay, thank you very much.
Thank you. Bye-bye. Good night.
Bye-bye.
Thank you.
Thank you.